and we have our very own Dr. Dwight Matthias from Grenada. And as I introduce start each of their presentations, I'll tell you a little bit more about each of them in turn to them. Dr. Marissa Tate from St. Kitts is also supposed to be assisting me tonight. She has actually been called out to an emergency, so she will hopefully come back and help me with that. All right. In the meantime, I'm going to be just moderating here tonight. So the objectives tonight, really, we're going to define chronic disease and the long-term complications manifested in Caribbean countries. We're going to list the prominent and emerging incidents of cancers, the rates of survivorship and mortality in Caribbean countries. And we're going to discuss potential hormonal mechanisms underlying the relationship between chronic disease and cancer. So as I say, it's a really hard-hitting program tonight that I think we're all going to enjoy. All right, so without any further ado, we are going to move to our first presenter. And the first topic is chronic disease in the Caribbean, looking from Dominica. And this is going to be presented by Dr. Andy St-Hilaire. Now, Dr. Andy, he did his medical degree at the University of the West Indies. And he has since then worked in Spain. He's worked for Ross University, for All Saints University of Medicine, Princess Margaret Hospital in Dominica. And more recently, since 2022, he's been on the National for Persons with Disabilities. He's been on board member 2020 for the Dominican Medical Board. And also, since 2022, he's been the National Coordinator for Non-Communicable Disease in Dominica. So you can see how he is definitely giving this talk. And since 2023, he's been the acting medical officer for the Ministry of Health, Wellness and Social Services in Dominica. So without any further ado, I would like to ask Dr. St-Hilaire if he will now take the floor presentation.
Thank you very much. Good evening, everybody. Thanks for being part of this exciting evening. Tonight, we are going to be speaking on non-communicable diseases, and we will start by a definition of non-communicable diseases. When we hear of non-communicable diseases, we think of non-infectious and non-transmittable diseases between people. Mostly chronic diseases of long duration, slow progression, which require chronic care management. So for the definition of a chronic disease, really, it's a long-standing condition that can be controlled but not cured. It generally persists for 3 months or more and may require ongoing medical attention. Examples of chronic diseases like diabetes, hypertension, asthma, and COPD. For non-communicable diseases, by definition, these are diseases that are not passed on directly from one person to another. They are often chronic and result from a combination of genetic, physiological, environmental, and to a large extent, behavioral factors. And examples are cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes. So in terms of the way we think of non-communicable diseases, in the beginning, it was grouped into 4 major categories: cardiovascular diseases, diabetes, chronic respiratory diseases, and cancer. But now, we are talking about risk factors. What causes or can predispose one to NCDs? In terms of the risk factors, we often think of modifiable risk factors and non-modifiable risk factors. The non-modifiable risk factors would include genetics, age, sex, race, and the modifiable risk factors really are smoking, alcoholism, unhealthy diet, physical inactivity, stress, environmental pollution, and socioeconomic condition. And these four major risk factors: tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, creates or help to cause the four diseases, the four main categories of NCDs: cardiovascular, cancers, diabetes, and chronic respiratory diseases. But as of late, we have added a fifth group of NCDs, and that is mental health. Mental health is very important. So now when we think of NCDs, we think of the five major groups of NCDs: cardiovascular, diabetes, cancer, chronic respiratory diseases, and mental health. There was a study done looking at the 10-year trend in non-communicable diseases and mortality in the Caribbean region. What happened is that the study examined the age standardized mortality rates and 10-year trends due to death from cancer, heart disease, cerebrovascular disease, and diabetes in 2 territories in the United States, that is Puerto Rico and the United States Virgin Islands, and 20 other English or Dutch-speaking Caribbean countries or territories from the most recent available 10 years of data ranging from 1999 to 2014. The results indicated that cancer, cerebrovascular disease, heart disease, and diabetes accounted for 39 to 67% of all deaths in these 22 countries and territories. More than half of these deaths in 17 of these countries. Heart disease accounted for higher percentage of deaths in most of the Caribbean countries and territories, ranging from 13 to 25%. Cancer accounted for 8 to 25%. Diabetes accounted for 4 to 21%. Cerebrovascular disease accounted for 1 to 13%. And the age standardized mortality rates due to cancer and heart disease were higher for males than for females. There was also another study done in the Caribbean, and it showed that NCD mortality in the region is the highest in the Americas. On average, people in CARICOM countries have lower life expectancy at birth than those in Central or Latin America. And we see a reversal of the situation that existed 30 to 40 years ago. 40% of NCD deaths occur prematurely in those under 70, and these are potentially preventable. Heart attacks, stroke, diabetes, and cancer, they are the leading causes of premature death. And hypertension is the leading risk factor for death. Diabetes prevalence is double in the region when compared to global rates. According to the surveys conducted in 12 CARICOM countries, 10 to 25% of adults have diabetes, and 20 to over 50% suffer from high blood pressure. In some countries, there are particularly high rates of undiagnosed hypertension. For example, 50% of people in Jamaica do not know that they are hypertensives. There was another study done in Jamaica where they looked at what is trending in public health. And what was observed in 1945, TB, heart disease, nephritis, syphilis, pneumonia, and influenza. These were the diseases that was trending during that time. You catapult forward to 1982, and then cerebrovascular disease, heart disease, malignant neoplasms, hypertension, and diabetes started showing its face. In 1996, cerebrovascular disease, diabetes, ischemic heart disease, hypertensive diseases, homicides, and assault. And in 2004, cerebrovascular diseases, diabetes, ischemic heart disease, hypertensive diseases, and other heart diseases were trending in the public health domain. The World Bank had worked in collaboration with relevant governments, and they recently finished an NCD care assessment in several upper middle income Eastern Caribbean countries. They looked at Dominica, and Dominica faces the burden of NCDs as the leading cause of death, with the prevalence of hypertension among adults at 22% and diabetes at 11%. Poor health behaviors and risk factors, these drive high rates of NCD mortality, with 60% of the population overweight or obese, and 11% of the population engaging in tobacco use. They also looked at Grenada. Grenada's National Health Sector Strategic Plan of 2016 to 2025 identified NCDs as the leading cause of morbidity and mortality in the country. According to WHO 2022 Progress Monitor, they observed 83% of deaths in Grenada are from NCDs. And there is a 23% probability of premature mortality from NCDs. So given this heavy burden of NCDs, improving NCD care is critical. Based on the data collected, they also showed that 40% of patients in treatment for only hypertensive or diabetes did not achieve control. In addition, 50% of patients had more than 6 months between the last visits. And while most patients would have their random blood sugar, glucose and fasting blood glucose monitored, only 7% had their A1C tested. St. Lucia, Ministry of Health, Wellness, and Elderly Affairs of St. Lucia reported that NCDs are the leading cause of illness and death in the country, with NCD causing 82% of deaths and 18% probability of premature mortality. Then, based on the STEPS survey, it showed that men between the ages of 18 and 69 are hypertensive, and 18% of female aged 18 to 69 are diabetic. So we do have a problem in the region in terms of our NCD rates. In terms of morbidity and mortality rates, morbidity rates increase hospitalization due to chronic conditions. So people visit the hospital more often, they are warded more often, and that creates a strain on our system. And the mortality NCD rates, they are responsible for approximately 70%. Some of the studies show 74% of all deaths in the Caribbean region. What about the economic burden? When we think of direct cost, we think of hospitalization, medication, outpatient care, and the indirect cost of loss of productivity, long-term disability, and the impact on the health system, where increased demand for services leading to resource strain. So we are talking about NCDs, but one of the major risk factors for NCD is really the behavioral risk factors: tobacco use, harmful use of alcohol, physical inactivity, and unhealthy diet. So in the fight for NCD, we really need to bring on behavioral psychologists in the fight in our region for NCD care. Preventing NCDs required a multifaceted system that targets lifestyle changes, policy intervention, and community outreach. So in terms of what we can do as community, what we can do as individuals, we have to look at our healthy lifestyle choices, what we eat, balanced diet, rich in fruits, vegetables, whole grain, lean proteins, reduced consumption of processed foods, sugary drinks, and high sodium products. Physical inactivity. We must encourage regular physical activities, promote active transportation, walking, cycling, recreational activities. Tobacco control. We must implement smoking cessation programs and support for quitting. Enforce strict regulation on tobacco advertising and sales, and encourage moderation in alcohol consumption and educate about the risk of excess drinking. Our policy interventions, regulation of food and beverage industry, implementing taxes on sugary drinks and unhealthy food products. Urban planning, develop infrastructure that promotes physical activity, example parks, bike paths, and the way we design our sidewalks in our Caribbean cities, and ensure access to healthy food options in community, especially in food deserts. Community engagement. We must have our support groups, establish community support programs for healthy eating and physical activity, and create environments that foster social support for behavior change. And we must have our collaborators. We must work with schools, workplaces, community organizations to promote healthy environment, and engage our local leaders and influencers to advocate for health promoting policies. So the new group of NCD, the mental health. How do we deal with stress? We must promote mental health awareness and provide resources for stress management, encourage practices such as mindfulness, meditation, and counseling. And we must have affordable healthcare services. So that is what we can do as community, as individuals, as groups. But as the Caribbean region, the Caribbean has implemented various health programs aimed at preventing and managing NCDs and promoting overall health. CARICOM has developed the CARICOM Regional NCD Strategy that promotes healthy lifestyles, strengthens health systems, and encourages regional cooperation in combating NCDs. There are NGOs like the Healthy Caribbean Coalition that advocate for health policies, engaging in health practices, and providing resources for individuals and health initiatives. Then from this, the Caribbean Wellness Day activities, where health fairs, free screening, educational workshops, physical activities across member states are encouraged. And PAHO has come on board, where they have initiated the HEARTS program and the Global HEARTS initiative in the fight against NCDs. The Barbados National Registry for NCDs provides vital statistics to inform public health policies and programs aimed at reducing NCDs. Cuba has a very good program where they have developed the Family Doctor Program and the Community-Based Health Education Program. And the Trinidad and Tobago National Health Promotion Program, they promote healthy eating, physical activity, and tobacco cessation. Jamaica has also developed the Jamaica National Health Fund, where they provide financing for medication for NCDs and health education. St. Lucia NCD Prevention and Control Program the community health education campaigns, where they increase access to screening and preventative services in the underserved area. And the Bahamas Health Promotion Prevention Program also does regular health fairs, workshop focusing on what we eat and the lifestyles that we have. So in conclusion, we address the root, if we address the root causes of NCDs through lifestyle modification, effective policies, and community involvement, the burden of NCDs can be significantly reduced. The public health initiatives play a crucial role in fostering environments that promote health and prevent diseases. Thank you very much.
Dr. Santilla, thank you for that very interesting talk. Thank you very much. And you kept to time, so you're making me happy.
Thank you.
Thank you so much. All right, so now we are going to move to a short special feature, which has been prepared for us by the Women in Medicine at St. George's University. And this feature is just a minute feature on HTLV1.
Have you heard of HLV1? It's a virus that affects 5 to 10 million people globally, especially in places like Japan, the Caribbean, South America, and parts of Africa. HTLV1 spreads through direct contact with certain body fluids, like blood, semen, and especially through breast milk from the mother to baby. So, unprotected sex, drug use, and tissue or blood transplants, and even being infected with HTLV1 while pregnant can put you and your baby at risk. Once you get HTLV1, the virus can cause diseases like adult T-cell leukemia, a type of cancer that affects different parts of the body. There's also HTLV1-associated myelopathy, a long-term problem that hurts your brain and spine, making it difficult to move and causing pain in your arms and legs. Sadly, there's no cure for HTLV1, but managing symptoms might involve antiviral drugs, cancer treatment, or specific care for issues caused by HTLV1. Therefore, prevention is of importance. To stay safe, it's crucial to test blood products, avoid risky behaviors, and use protection like condoms. If you suspect exposure to this virus, it is crucial to discuss and request a test with your healthcare provider. Let's all take steps to prevent HTLV1 infections in our community.
Well, a big thank you to St. George's University's Women in Medicine. I think that was a really, although very short, it was very to the point and very informative little video there on HTLV1. So without any further ado, just one piece of housekeeping before we go on. Those who want to receive CMEs for this event, if you can put your email in the chat so that we can make sure we capture everyone. And also, if you have any questions, we are going to have a question and answer session at the end of the 3 presentations. So if there are any questions that come up that you think of as you're going along, just put them in the chat and we will keep a record of them, and then we'll try and answer as many as we can at the end. So now we're moving to our second talk, which is on cancer in the Caribbean in Antigua. And this is going to be presented by Miss Valerie Williams. Now, Miss Valerie Williams from Antigua is a registered nurse, a certified midwife, and she has work experience both as a ward sister in Halberton Hospital in Antigua and also a ward assistant with quality assurance nurse management at the Mount St. John's Medical Center. She's also acting director of the Directorate for Gender Affairs, and she is presently the non-communicable disease coordinator in the Ministry of Health and Wellness, Social Transformation and the Environment for the past 11 years in Antigua. She also loves nature and outdoors, so she's keeping healthy herself. So without any further ado, I'm going to ask Miss Williams if she will start her presentation.
Just a second. Good evening. Internet is not cooperating with me this evening, so just hold a second.
We're hearing you very well.
Okay, yes, I think the internet was going in and out. Good evening again to everyone. So let's look at some cancer statistics. So the leading causes of death worldwide. We have 65% of all cancer deaths occurring in the less developed regions of the world, which include our Caribbean region that we're looking at this evening. And in the Caribbean, cancer is the second leading cause of mortality, with an estimated 87,430 cancer-related deaths reported in 2012. In 2022, cancer accounted for 1.4 million deaths, which is 45.1% of the total number of deaths which occurred in people of 69 years old and younger. So, what action can we take? Countries have begun to establish national cancer control plans as means of defining the strategies and interventions and resources that will be devoted to prevent and control risk factors nationally. Some cancers can be prevented. Others, if detected early and treated appropriately, can be cured. The exact cause of cancer is unknown. However, there are some proven risk factors associated with cancers. Now, when we look at the most common cancers that are affecting the Caribbean, we look at prostate cancer, which accounts for 15% of all cancers. And in the region as well, it ranges from 18.4% to 47.4%. Breast cancer accounts for 14% of all cancers. And from country to country, it ranges from 14.0% to 29.7%. Colorectal cancer, I think that should be 18% of all cancers, and that ranges from 4.9% to 18.1%. And cervical cancer is 9% of all cancers, and it ranges from 4.5 to 18.2%. We also have hematological cancer, which in some areas it is reported that it is less than 4%. And because it is something that is kind of not too permanent in some places, there's not much data available in it. But what I found as well is that hematological cancers in children especially is like 1.4%. So it is a very small number. And so it's not been captured in a lot of the countries. Of significant note, the cancer of the lungs, which was number 3 at some point in the region, has now been surpassed by cervical cancer simply because there are more deaths in the region from cervical cancer than deaths from tobacco smoking or the lung cancers. So prostate cancer is the leading cause of death among males in the region. Afro-Caribbean men have a higher risk of prostate cancer than any other population of men in the world. These tend to be more aggressive and have poorer outcomes, having been linked to African ancestry. One of the reasons is that most of the countries, we do not have access to treatment and to care. And men, as our African-American men, are poor health seekers. So a lot of time they only being detected at a very late stage. So there's not much that can be done for most of them at that time. Many prostate cancers grow slowly and are confined to the prostate gland. If detected early, when it is still confined to the prostate gland, it has the best chance of a successful treatment. Advancement in diagnosis, active surveillance, and surgical management of prostate cancer have resulted in improved cancer control and overall reduced morbidity and mortality from the disease and treatment. Age and race, again, it has to be stressed, have been linked as major factors implicated in the development of prostate cancer. Access to screening, biopsy, and appropriate treatment contribute to survival rates. And the truth is same to if persons are not able to access those. Breast cancer is the most common cause of cancer death in women in the Americas, and this accounts for 30.7%. In 2020, there were more than 210,000 new diagnosed cases of breast cancer in Latin America and the Caribbean, and there was close to 68,000 deaths from breast cancer. What puts women at a higher risk of developing breast cancer? Obesity, alcohol consumption, family history of breast cancer, exposure to radiation, reproductive and hormonal history, and tobacco use. Around half of the cases develop in women with no identified risk factors other than the female gender and age 40 years and older. Most commonly presents with a painless lump in the breast. It is important that women finding an abnormal lump consult a health practitioner as soon as possible, even if there is no pain. The burden of breast cancer can be reduced by identifying and treating cancers early before they give any symptoms. Colorectal cancer. Colorectal cancer develops in the innermost tissue of the colon or the rectum, also called bowel cancer or rectal cancer. The exact cause is not known, but there are some factors that contribute to the cancer, including inherited and acquired gene mutations. Most colorectal cancers start as a growth in the inner lining of the rectum called polyps. They may not cause any symptoms, especially in the early stages. However, changes in bowel habits, rectal bleeding, persistent abdominal discomfort, unexplained weight loss are symptoms you should speak with your doctor about.
Just sorry to interrupt. Are you moving whoever's moving the screen on, the screen is still on cervical cancer?
Oh, I'm seeing colorectal cancer and I'm not actually touching it. Yeah, I've seen movement on my screen, but that's
Okay.
not. So are you seeing colorectal cancer now? Because that's what I'm looking at.
I am not.
Oh.
Let's share the screen, maybe.
Okay, let me see.
Hold on. Okay, moment.
No, we're not there yet.
Just
That was first. Are you seeing colorectal cancer?
I am not.
No.
Oh.
I can share from my end.
Okay, thanks, Dr. Telesford. Yeah, sure.
Can you stop sharing, please, so I
Sure.
can share from this end? Okay. Yeah, you should be seeing it now.
Yeah,
Colorectal
but can you
cancer.
enlarge it a little bit for me?
Yes, I think we can all see that now.
Okay. Can you enlarge a little bit, please, Dr. Telesford? Okay. So I'll go over the colorectal cancer then. So colorectal cancer develops in the innermost tissues of the colon or rectum, and they're also called bowel cancer or rectal cancer. The exact cause is not known, but there are some factors that contribute to the cancers, including inherited and acquired gene mutations. Most colorectal cancers start as a growth in the inner lining of the rectum called polyps. The cancer can develop without causing any symptoms, especially in the early stages. However, changes in bowel habits, rectal bleeding, persistent abdominal discomfort, unexplained weight loss are symptoms you should speak with your doctor about, because this could indicate that you're having colon cancer. Colon cancer is beatable with early detection. Get your colonoscopy done. Recent predictions of colon cancer mortality to the year 2035 indicate that mortality rates from this cancer will continue to rise. And one of the reasons is that in most of our health systems, even when persons are trying to get early interventions, because of the limited resources, we have delay in getting tests done, the screening. And again, because we stated that most of these cancers occur in the low-income countries, there are some persons who are not able to pay for these tests. And so they tend to keep putting off having the screening done until it's too late. Next. Next slide, please. Hematological cancers. These are cancers that begin in the blood-forming tissue, such as the bone marrow or the cells of the immune system. They include things like leukemia, lymphoma, multiple myeloma, non-Hodgkin lymphoma, and Hodgkin lymphoma. Leukemia especially is something that cannot be cured, but can be treated. And so persons with this form of cancer as well has a high rate of disability in terms of it's a long-term treatment options and all the illnesses, the doctor's visit. So these persons sometimes end up not having treatment on a regular basis, and then they have a poor quality of life. And so there's a loss of time from productivity from work and these kind of stuff. In children, it is interesting to note that as children get older, most of these hematological cancers becomes less. So they're less prevalent in older children, but in adults, they tend to start showing up from a later age, especially after age 61. Next slide. So looking at the prevalence and the trends, it is projected that cancer incidence will increase by 58% and mortality rates by 67% by 2035. So an estimated 1.5 million new cancer cases will be seen, with 700,000 deaths predicted over in Latin America and the Caribbean region by 2035. So we look at the responsible factors for this increase. We have an aging population. So as persons get older, you tend to develop some of these diseases, which you're not able to do anything about them because of your age. I mean, they just increase as you get older. Lifestyle-related risk factors include physical inactivity, dietary patterns, reproductive behaviors, obesity, alcohol, and tobacco consumption. And again, these are the same risk factors that we speak about for all our non-communicable diseases. And so you see the interrelationship of these cancers and your diabetes and your hypertension. Again, they're all non-communicable diseases. And because we look at the lifestyle factors which are responsible for them, it means therefore, if we take our health and look at our lifestyle practices into consideration, reduce weight, use less sugar, become more physically active, and reduce the consumption of alcohol and tobacco use, we can then reduce our risk factors and hence reduce the prevalence of cancers. The presence of human papillomavirus. Now, all of women, as long as you're exposed to sexual activity, you're exposed to the human papillomavirus. We know that the younger you are, the easier it gets cleared. But although we have the evidence that vaccinating all our girls, well, at least 90% of our females by the age of 15 years with the HPV vaccine, in the countries in which this HPV vaccine have been rolled out, unfortunately, most of them, the uptake has been very low. So that primary prevention mechanism is still not being at the level and the rate at which we would have expected it to be in the Caribbean region. Also, for the secondary prevention, having women from age 35, 70% of those being treated, screened with a high performance test, which is the HPV test that is the treatment screening option or screening test of choice. If we have 70% of all those women who are eligible to be screened and treated, whether they show any signs of precancer or cancers, again, there's some inequity there where the treatment is available, yet some persons are still not showing up to be screened. And even in terms of them having appointments for follow-up visits and stuff like that, they are not showing up for the treatment. And hence, we're looking at an increase in the number of cancer cases in the region. Next slide. So because of all of what is happening, economic burden. Went a little bit too fast. Okay. The economic burden on our region is huge. The cost of healthcare is already out of the reach of some persons, where we're already in low-income countries, and some of our women are at the lower end of the salary scale. Hence, they're not able to pay for some of these screening tests or for the interventions that is required if and when they are affected with some of these cancers. Also, there's lots of work due to complications for cancer diagnosis, the comorbidities, unequal access to treatment and care. And it has been reported by some persons that even to take time off from work for doctor's visit, for treatment and stuff like that, there's lots of earnings. And some people actually weigh like, do I prefer to go get my treatment and not get paid, or I go to work and skip my treatment? And so sometimes your health is being not given the priority it should because of economic concerns. All persons with cancer can benefit from appropriate treatment and palliative care. However, some persons are unable to access these. An essential package of cancer prevention and control intervention is estimated to cost about 3% of the total public spending on health. And we are seeing in the region that a lot of times financing for health is not where it should be based on what is happening health-wise in our country. And so again, we are shortchanged there in terms of public spending on health. So it is prohibitive for many countries in the sub-region. And so innovative funding mechanisms may be the solution to help with the spending that is not being provided by the country through your government funding agencies. Treatment availability and success in the Caribbean. Now, this one is a cancer, cervical pre-cancer treatment services available with colposcopy, cryotherapy, LEAP, LEADS, and our whole knife conization. Pathology services for cancer diagnosis. We have cancer surgery, radiotherapy, chemotherapy, palliative care access as measured by opioid consumption with morphine equivalent minus methadone. These are available in most of the regions in the Caribbean. Oh, I think we're missing one of the slides. The one for time to take action, I
I think
think.
we're kind of, yes, maybe very quickly, we're kind of
Okay.
middle over
Yeah.
time. So we're going to
So
wind
time
up.
for action. So we need to advocate for prevention strategies and policies to tackle obesity, tobacco smoking, HPV vaccination, look at early detection, screening, and cancer care improvements. A comprehensive cancer plan can reduce cancer mortality and improve the quality of life. So while it is encouraging to note that almost all countries have initiated plans, it will require efficient health systems with sufficient financial and human resources to ensure accessible quality cancer care. Thank you.
Thank you so much. I'm sorry to rush you there at the end, but there's so much information that it's hard to slot it all into a 15-minute piece. So well done. It was very, very informative. I think people will have found that very interesting. And
Thank
now
you.
before we move to our last speaker, maybe, our main speaker who's going to tie these topics together tonight for us, we're going to have a small feature. And this is a feature from Grenada on men and prostate cancer.
What happened? You alright? You look worried.
Everything alright.
Kyle, come on now. This is not the first time I see you looking like this. What's happening? What's going on?
It's, well, the dripping thing, man.
Oh, that's unusual. Maybe you should go and check it out by the doctor.
Nah, it's probably nothing. Don't want to waste them people's time.
Kyle, please. Your health is important. Promise me you'll make a call tomorrow.
Alright. I'll give him a call tomorrow. Something ain't right.
Yeah? What's wrong?
It's personal. Sarah keeps telling me to go see a doctor, but
Listen now. One woman says something, it's because they love and they care. That's what she's talking from. Yeah? So they just worry about me. So maybe you should listen.
yeah. Oh, listen, man. Yeah, I'll listen.
Yeah, man. That's the attitude. Let me drink to that.
So your results came back. It seems that you have
You good, man? You've been quiet all evening. What's up?
The results, they weren't good, man.
We get through this together. So, tell Sarah. You know that.
Yeah, man. Thanks. I will.
okay. I think he finally went to get tested. He acting strange, but scared. What if
Sarah, breathe. You're not alone in this. No matter what the results say, Kyle needs your support. And you have mine too. Remember that website I mentioned? It has information and resources for both patients and their families.
Yes, I understand that. What's the name of the website again?
www.karenkhan.org.
Thanks. Thank you so much. Thank you for the support, Kate.
Sarah, I have something to tell you. The doctor said that I have prostate cancer.
Oh, Kyle. I'm so sorry. But you know what? We will fight this together. Really spoke to Kate, and she mentioned the website. And there's all sorts of information about, support that we can use.
Sir, I would not have been able to do this without you. Thank you for allowing me to go get tested.
Not a problem, babe. That is what family is here for.
Early detection and treatment are crucial in the fight against prostate cancer. Encourage men to talk to their doctors and get screened regularly. Sign up to the Caribbean Cancer Portal for more information and support.
Whoops, there I am, unmuted. So thank you to Grenada for that very informative video. I know some people were finding that the audio was a little low, so I apologize for that. I think it's internet up and down for people. But I think that had a very, very strong message. As we know, prostate cancer is rife within the Caribbean, within our men, and early detection is definitely the way to cure. So I think everyone needs to take note, and it doesn't matter how many times we play that video, it stays just as important. So now we're going to move on to our final speaker, and that is Dr. Dwight Matthias. And he will be speaking on tying in cancer and chronic disease relationship. Having heard from both the chronic disease side and the cancer side, now Dr. Dwight's job tonight is to tie both those things in. And just to let you all know, those who don't know Dr. Dwight, a little bit about him. He practices both general endocrinology and internal medicine in Virginia, USA. And twice a year, he comes down to Grenada to do a general endocrine clinic. He's a former student in Grenada, of Grenada's Boys Secondary School. And he received his Bachelor of Science degree in biological sciences with emphasis in genetics at State University in New York, Buffalo. He completed his medical degree here in St. George's University in Grenada, and he was eventually accepted to Stanford University, where he pursued a fellowship in endocrinology, focusing on pituitary disease and testicular dysfunction. After completing the fellowship, he became an assistant professor of medicine in the Department of Medicine at Eastern Virginia Medical School, and subsequently transitioned into private practice. He's lectured both in America, the Caribbean, on diabetes and its complications. He's been published in several peer-reviewed journals, and he's a fellow of the American College of Physicians. He's very dear to our hearts. He continues to support Grenada and the Caribbean through his teaching on endocrinology. He's happily married. He has a son, Dwight Jr., and he continues to support us all. So without any further ado, I would like to have Dr. Dwight start his presentation. So thank you.
Thank you all, and welcome all tonight. It is a momentous task that I've been given here to tie these both extremes together, but I'll do my best. And I will be given some basic sciences. So guys, I'll try my utmost best not to go too deep. So I'm connecting the dots between cancer and chronic disease. And where will that dot or dots bring us will depend on the questions you ask. So my intention tonight is non-communicable disease increase the risk for cancer, or is there a hormonal influence? As we looked at our previous discussion, my aim is to present how or is there an interplay of endocrine hormones or factors as the potential mechanism, and how risk factors individuals may have that may affect the target organs, the breast, prostate, etc. And are they providing those hormonal influences? Are they providing the microenvironment for that cancerous expression? So as an endocrinologist, we look at many organs from the hypothalamus pituitary to the thyroid, and then we have the pancreas, the adrenal gland, the ovaries, and the testicles. We also pay emphasis on the parathyroid gland and the pancreas in terms of insulin and the relationship with glucose. Now, I put the slide here just to represent how intricate, how it interplay with the different glands in the body and the outcomes. For example, the adrenal gland influenced by the pituitary action, we have the outcome of cortisol. And that is related to stress, how stress plays a very important role in the release of cortisol and the metabolic effect that has. In addition, the thyroid hormone, the interplay of the thyroid hormone in our metabolism. And in addition, the production of estrogen and testosterone, which has an influence. Now let's look at the data that is out there. You can see that chronic disease in the Caribbean in 2019. I highlighted Grenada, I highlighted Dominica, and Antigua. You can see that there is a cluster of the small islands on one end with great incidence of the chronic disease. And the question is why? Why our small islands have such a high incidence of chronic disease? Let's look at the facts. This has been noted in 2007. The heads of government of the Caribbean saw that there was a great need to bring to action by uniting to stop the epidemic of chronic non-communicable disease in our region. And they deemed that the second Saturday in September should be coined as the Caribbean Wellness Day to address issues of cardiovascular or cerebrovascular accidents, strokes, cancer, diabetes, obesity as the leading cause of illness and death, as we have heard earlier from our prior two speakers. But looking at the whole scenario, what is the interplay of all these chronic disease and cancer? Looking through the eyes of adiposity simply means excess adipose tissue, hyperinsulinemia, which we'll go in detail later, and glucose. How do they play a role in the cancer and in terms of chronic disease? I recently had a discussion and with one of my colleagues when I was asked to present this, and I requested information on cancer in Grenada. And this is the outline. This is raw data. It has not been totally scrubbed, but I thought it was significant to present this during this discussion. We recognized in 2007, when the Caribbean heads of government brought out the highlight that cancer is significant within our region. And you can see, most likely through the information, there was a downslope. And in 2019, there is an uptick, and there continued to be an uptick in cancer. The question is why? We know that COVID occurred during this period of time in 2020, but I will not make any assumption yet. When we look at cancer in Grenada from 1994 to 2024, we noted that breast cancer is predominant, followed by prostate cancer, and we have series of other cancers that exist. Looking at breast cancer within our parishes in Grenada, St. Andrews and St. George's, bigger parishes, the incidence of breast cancer is tremendous. And in St. Patrick's, I think this speaks for itself, the incidence. The blue bar represents 2024, as the yellow bar represents 2021 in the incidence of breast cancer within our areas in different parishes. When we look at prostate cancer by parishes, it mirrors our breast cancer to a degree that St. Andrews and St. George's, followed by St. Patrick, has higher incidence of prostate cancer. So they also crunch the data looking at chronic disease in children to see if at an early age, our kids having diabetes, etc., or some chronic disease that exists there. And we get a slight uptake in diabetes per se. There were no sort of solid organ cancer during that time. So the question I asked my colleague, basically, I said, listen, I complete clinics in Grenada for several years. But in 2019, I specifically started a diabetes clinic of the 2 days that I'm on the island for the whole week, looking at diabetic patients. And here is the number of patients I've saw since that period of time, 2019, 129 diabetic patients between the age of 5 to 86. Obviously, in 2020, with the advent of COVID, this was a March visit, February-March visit, only 43 patients that year. And when I restarted the clinic, 162 patients in 2023. And earlier this year in March, I saw 95. And on my return visit, most likely this number will increase. So I wanted to pair this diabetes with the cancer during that set period of time. And surprisingly, if you look further, of the uptick of diabetes with cancer at that time. So as an endocrinologist, thinking about diabetes and cancer, what relationship is occurring there? We know at the time of diagnosis of diabetes, you have already lost about 50% of your beta cell function. And then there is a progressive nature of diabetes. So the question is, what was occurring prior to the diagnosis of diabetes? What microenvironment exists that could or maybe contributing or supporting the progression of cancer? We know of the impaired glucose tolerance phase and the postprandial hypoglycemia before the individual is diagnosed with diabetes. And the central culprit here is insulin resistance. And insulin resistant is a disorder that results from producing excess insulin to maintain an optimal blood sugar reading as a result of visceral fat accumulation. It could be genetic, it could be from ethnic or environmental, and that in turn leads to an inflammatory process, leading to gradual increase of blood sugar with compensation with high insulin. And in such a case with insulin resistance, the onset of hypertension, high cholesterol, endothelial dysfunction, atherosclerosis, coagulability defect, increased free radicals, oxidative stress, and the onset of diabetes. That this insulin resistance plays a very important role in providing the environment for our cancer cells to progress. And some of these markers we look at for insulin resistance, that you and I, or those clinicians within this talk, we see it quite often in our clinic. Many of these patients may have high basal insulin, and that can be measured through a fasting blood sugar. There may be central obesity, skin tags, acanthosis nigricans, the dark pigmentation around the neck. Females with polycystic ovaries. If lipid panel is done, you may see high triglyceride and a low HDL. The gradual increase in blood pressure and increased blood sugars. So we can identify in our clinical environment many of the markers of insulin resistance. And this is just showing the complexity of the insulin resistance and its relationship to type 2 diabetes, the obesity, and how that works. In terms of obesity, these cells go through a transformational change, and as a result of that, the aromatase activity in these cells may lead to high estrogen production. And high estrogen production, if there is a potential tumor cell in the breast, it may be the progenitor for that environment for that cell to grow. In terms of obesity, you create that insulin resistance. And the hyperinsulinemia with beta cell failure, because the beta cell, which produce insulin, cannot continue in that process of trying to compensate for a period of time. And once you lose 50% of beta cell function, you become diabetic and with increased blood sugars, hypoglycemia. And that provides an environment for increased tumor cell growth. We may also look at our intestine microbiome. The bacteria within our gut may even play a very important role, leading to the production of adipocytes, proliferative factors that may influence the tumor growth. So this is a very complex, intertwined phenomenon that occur with obesity, the insulin-resistant picture. And as insulin-resistant picture in terms of the liver, it leads to the production of insulin growth factor. And that is allow the growth of the tumor cell. As we go further, we know that obesity has risen dramatically, as we have learned earlier, in the few decades ahead. And that is due to changes in our diet, physical activity patterns. Because I'm sure today, our first speaker talked about our sidewalks to be able to move from one area to the other rather than driving continuously. With increased obesity, we know that there are about 13 anatomic sites that can lead to the cancer: endometrial, esophageal, renal, pancreatic, liver cancer, gastric cancer, meningioma, multiple myeloma, colorectal cancer, breast cancer, ovarian cancer, and thyroid cancer. And there's a strong relationship with that. And many of our regional organizations has deemed obesity as a disease. CAFR, the Antigua, Barbuda, NIS, the American Association of Clinical Endocrinology, the American Academy of Family Physicians, and many of the World Organization has deemed that. And we know that obesity may be a contributing factor for many health risks. And those health risks which I will show in a couple minutes. But what during my search, which was quite interesting back in 2007, one of our physicians over in Jamaica, he wrote an article, and it shows that BMI, body mass index, explain in the bottom of the slide, explain 26% of the variance in blood pressure in females and 13% in males. And obesity is a significant problem in the Caribbean. And as we look at obesity in the Caribbean, and some of this stat has been alluded to earlier, the highest rate of overweight and obesity in the Americas in Antigua and Barbuda, 18.9%. In Barbados, a very high number. And what is very important, 30% of Caribbean adolescents are obese. And I should know there is a conference coming up at SGU in a couple of weeks or probably in a month or so about obesity in the adolescents. And the prevalence of childhood overweight obesity, that's 5 to 9 years in CARICOM countries, are increasing. Does that mean that there will be an increase in cancer incidence within our islands? And we know that obesity in Bahamas, 39.5%, and it's lowest in St. Lucia, 26.1%. And the prevalence of obesity in the Caribbean children is 2 to 3 times higher than that of the world. The question, why is that? As we look at obesity, type 2 diabetes is prevalent in these individuals. Diabetes risk, pre-diabetes, high cholesterol, blood pressure elevated, cardiovascular disease, fatty liver, reflux disease, infertility in females, male hypogonadism, because with the production of testosterone, it is converted to estrogen in the fat tissues by the enzyme aromatase, sleep apnea. Obesity may lead to asthma, osteoarthritis, urinary stress disorders, and depression. So, with a normal lean fat cells, when it's exposed to high caloric intake and decreased physical activity, it goes through some conformational changes. It hypertrophies. And as a result of that, we have it, macrophage infiltrate and it accumulate lipids, etc. And due to this change, due to this conformational change and its ability to create all these toxins, it becomes a dysfunctional adipose tissue. It houses many factors that influence the growth of cancer. It alters the protective cell nature of our cells. It increased leptin. Leptin should control our appetite, but in this case, leptin now become extremely high because there is a resistance that exists. And the decrease in adiponectin, which should increase insulin sensitivity, but now it doesn't. It becomes insulin resistant. And this high insulin resistance, as I alluded to earlier, propagates and does lead to the macrophage proliferation. So we can see that adiposity, increase in fat cells, has a higher incidence and of cancer and mortality rates because it provides the microenvironment for these abnormal cells to proliferate. Now, if we look at the fat cells, this is just for the scientists who are in our midst. This is just showing that someone with breast cancer and aromatase activity that in the normal individual is very low towards the lower left. And with those who have the tumor, the breast cancer, you can see that more of the adipokines or the factors that lead to proliferation of cancer is very high in these tissues. And on the right bar, we can see in normal weight individuals how less these proliferative factors are compared to those who are overweight, giving us a better insight that obesity can become a very toxic, a very mitogenic or environment that promotes growth of cancer. It's a complex scenario I am attempting to put here, but due to the sake of time, We know that there may be some genetic susceptibility why someone develop insulin resistance. And because of environmental factors and genetic reason, you may develop obesity. And there is this interplay, the decrease in certain hormones that help us with our satiety, that help us with our hunger, that help us with our fullness. That's why these drugs today, the glucagon-like polypeptide, the semaglutide that are there, it decreases our hunger and increases our fullness, and that leads to the weight loss. And this is the major drug in today's environment here in the States in terms of treating diabetic patients, because there are tremendous benefit with these drugs. But contrary to the whole scenario that you have in front of you here now, the obesity is the driving factor leading to the cancer proliferation, the mitosis, the division of the cancer cell, the DNA damage, the programmed death is lost. There isn't anything to tell cells anymore. It's enough. The migration, the metastasis of the cancer. So we know that insulin resistance leading to hypoglycemia can lead to that. And this is just highlighting the main mechanism and pathways between obesity and insulin resistance. And even some diabetic pharmacotherapy may contribute to the cancer. And that can go into further discussion later. This is just highlighting again how hyperglycemia contribute to the angiogenesis, the vasculature of cancer, the proliferation of cancer cells, the prolonged survival of cancer cells, how it metastasizes and migration. All these different negative factors as a result of elevated blood sugars contribute to cancer growth. Yes, diabetes with its characteristics lead to cancerous environment, lead to scenario. Is that directed to me?
No, I think that was an accidental mic on.
Okay. Now, saying all that, we need to know what can be done to help improve or decrease the incidence or decrease the mortality. Number one is very simple. This is a graph showing, the blue line showing inactivity and the incidence of cancer versus the bottom dotted line shows the physical activity. So with physical activity, we can observe that the cancer incidence will will decrease compared to inactivity. And here the cancer mortality rate in individuals who are more active will also decrease. So physical activity plays a very important role. If individual, after consulting with them in terms of lifestyle change, and you're not achieving that goal, there are many pharmaceutical agents out there that may contribute or assist with weight loss. And I just wanted to show you here of the different agents that may contribute to weight loss. The liraglutide, which is a GLP-1, as you can see in regards to the decrease in weight loss. And today we have more longer acting incretins or glucagon-like polypeptide compounds. Again, we have different surgical procedures that can be done to assist with weight loss. We have the gastric banding, the gastric sleeve, and the Roux-en-Y, which may contribute to that. We know that metformin plays a very important role because there are many papers out there that shows metformin is anti-proliferative. It shows some benefits, indirect and direct, in regards to insulin action. In other words, it leads to increased glucose uptake in the peripheral tissue. It decreased glucose neogenesis, the production of sugar at the liver. It increased lipogenesis at the fat cells, thus improving the environment of not being cancerous or leading to cancer production. In addition, the main adenosine monophosphate, metformin has a direct effect on that, and it increases cell death, those cancer cells. The cell cycle, the proliferative nature of the cancer will be inhibited, et cetera, et cetera. So we know metformin is beneficial in the context of breast cancer from both the preventative standpoint and the neoadjuvant and adjuvant standpoint. That is to say, in collaboration with other agent, and it inhibits the expression of aromatase activity that may exist. And here, this is a recent published that came out this last 2 weeks in my endocrine journal, stating that GLP-1, that's the semaglutides, etc., and the other incretin products, tied to a lower risk for 10 types of cancer compared with insulin use in a diabetic patient. And here you have the list of cancers that showed some improvement: colorectal, endometrial, esophageal, gallbladder, et cetera, et cetera. And if you look at the panel A, the incidence of colorectal cancer with patients who are prescribed the GLP-1 glucagon-like polypeptide drugs and insulin, you can see in the brown bar that the decreased incidence compared to insulin users. In slide B, you can see here with metformin users and GLP-1, there's a comparable decrease in the cancer type. And also in C, in panel C here, the incidence of liver cancer for patients prescribed with a GLP-1 and insulin, the marked difference you see here. So we now have products that can help with the weight loss if lifestyle change becomes an uphill struggle. And when I say lifestyle change, I'm referring to increased physical activity and to decrease the high caloric foods that are present in our region. Yes, there is a plethora of diabetic drugs out there to help manage the blood sugars. Some of them are beneficial in terms of lowering the incidence. And yes, there are some diabetic drugs that has been shown at a very minimal incidence, such as the TZDs, the pioglitazone, and the rosiglitazone. The rosiglitazone is off the market now. They have been shown to cause bladder cancer. So here, I just wanted to outline to you some of the drugs out there that we use to help with managing diabetes. It's an exhausted list, and these are the drugs we use today in our environment in treating diabetic patients. So what we have just seen briefly here, and hopefully I've done a little justice, but I didn't go in much detail, is that obesity and type 2 diabetes, the common connectivity here is insulin resistance. This creates an inflammation that may provide a cancer risk and increase mortality from cancer. And the treatment therapy that we use for the cancer may also lead to obesity. So we have a continuum of cycle here, and it can be an uphill struggle in dealing with diabetes and cancer. So non-communicable disease and cancer, obesity and diabetes contribute to the development and progression of specific cancers. And the therapies that we use may alter. So before I finish, I want to acknowledge my colleague from Don Pierre helped with the statistics earlier regarding Grenada, and many of the Grenada data has been from the General Hospital, St. George's University, Dr. Yearwood. I extend thanks to him for sharing his data on prostate, etc., and Dr. Goodwin Coy at the General Hospital, Nurse Bagwan, thank you. And we even got data from Lockwood from the funeral homes in Grenada, and we are still mining that data so we can correlate more with obesity, etc., and see how things go from there. So with saying that, I know I rushed through everything with a set of information here. I want to thank you all for your attention and questions so I can go in more detail after. Thanks. much.
Whoa, well, Dr. Matthias, wow, that was a roller coaster. That's a lot of information. I feel we almost need to come back and have a whole nother event just to target on this. You know what I mean? And really, you did a very good job bringing the two things in, because this is a huge topic, So I think we're going to take, I mean, I know we've run a few minutes over, but I hope people will be so interested that they'll want to stay on for a few extra minutes. We do have.
You're muted.
Wow, sorry. Okay, I was saying thank you so much to Dr. Mathis. That really was a tremendous presentation, tremendous. And it's not easy to tie in those two huge topics in such a short time. And I'm saying we'll probably need another CME event just to go through some more of it. I think there must be so many thoughts in people's minds. I think we're going to have just a very, very brief presentation from Antigua, I think, Lindonna, and then we will go into some questions. I've got just 3 questions in the chat. So people, if you want to put a question in the chat, please do. We can also take some individual questions as well.
There's a storm inside, but I'm still standing tall. Every step I take, I'm stronger through it all. You think you know defeat, but I'm here to survive.
Maraming may mga asawa sa tingin. Pakita mo sila nagsisimba, alam mo, kumakain sa labas, that's fine. Pero yung may panahon kang
In every scar there's a brand new spark. We're warriors made of fire and grace, rising together in a sunless race. We are the fighters, we are the brave. In the face of fear we stand unafraid. Through the tears and pain we rise again. Together we'll break these chains. We are the fighters, we are the brave.
Thank you so much for that. Of course, we will all know that October is Breast Cancer Awareness Month. So that is a very apt little video that we have there from Antigua. So thank you so much. Okay, we are now going to go into a few questions. Just the questions that I've pulled off so far. We did have a question to do with the first presentation, when we were talking about HPV, and there's a question, does vaccine to adolescent males help prevent cancer in women? So that's one question for the panel.
And the answer to that is yes. I'll take the first go at that.
Thank you.
Because at the end of the day, if the male is not treated, the male is exposing the female when they do have sexual intercourse. And I'm pleased to say that here in Antigua and Barbuda, we do vaccinate our males from the age of 9 to 13. So we do HPV vaccination for both male and females in Antigua.
That's perfect. And then another question which was related to that one was, should boys be vaccinated? Well, I think you've answered that question. They definitely should be. But also, is there a way to check men whether they're carrying HPV? Now,
unfortunately, I don't know there any approved tests, but then it shows up with the men when they show up with genital warts.
Exactly. So unless they have visual signs of it, there is no recommended test, unlike women who can have the cervical smear test. There is none, and that's one of the risk factors and one of the most important reasons why the boys need to be vaccinated, so it prevents them carrying it in the first place. I have a question here in the chat along that. What are the treatments available for HPV?
Okay, so we did go through those in our discussions. So starting with your precancers. Do you hear me? Okay. My internet is...
Yeah, no, we're hearing you.
Okay. So for our precancers, we do our colposcopies. Oh dear. Not sure what's going on with my internet. Okay. So we do have the colposcopies for the positive HPV test. And then once you do your colposcopy, then we can move on to, the other treatment, whether we have to do ablations, thermal ablations, or sometimes you have to do the colonization, so you're freezing the cancer in situ, or you have a removal of the cancer, or in some rare cases, some persons end up with a hysterectomy, or they get chemotherapy or radiation. So there's quite a few treatment depending on what is going on there.
Thank you. And then we've got Jean Beckles in the chat put that men can have a urethral swab for HPV. So thank you. Okay, and I just want to correct that little video was actually from St. Kitts. So my apologies, not Antigua, that was from St. Kitts. So thank you, St. Kitts, for the video that we had. The other question that I had in the chat, it was, is there a recommended age at which to do a colonoscopy? And what determines how often it's repeated?
Okay, so the recommended age is age 40. However, if you have family history, especially like if you have a mother or a sister or brother who died from colon cancer, it is recommended that if you're not yet age 40, that 10 years before the age with which that person died or was diagnosed with the rectal carcinoma is when you should be tested. You should have your colonoscopy done. Also, it's recommended that you do a colonoscopy every 5 to 10 years, but that is dependent on whether or not there's any positive thing coming out of your colonoscopy. Because if the doctor found that you had a polyp, then they would want to go in and do some interventions. You may have to have your polyp removed, have a piece of it sent off for pathology testing and stuff like that. If there is no positive result, then it's recommended that you can have it every 5 to 10 years. But if you have strong family history, the recommendation is for every 1 to 2 years for your repeat until the age of 75.
All right, thank you. Now, I'm not seeing any more questions directly in the chat. Is anyone else got a question? If they want to put their hand up, raise their hand, ask a question directly. Okay, Guido, would you like to unmute and ask your question?
I'd like to direct this question to Dr. Dwight Matthias. Dr. Matthias, from the intervention of the work you have done in Grenada, have you been able to find any relationship between diet and lifestyle linkage to prostate cancer in men and breast cancer in women, particularly in the Grenada environment? Thank you. Dwight. Mm-hmm.
Well, let me give a disclaimer here. Dr. Marshall Gaidu is my former teacher at Grenada Boys Secondary School. So here I am being challenged by my former, shall I say, mentor. Thanks for that question. It's very important in looking at diet and exercise. It should always be a staple in all medical therapy. It should always be upfront. Diet and exercise is very important. As I showed in this slide here, that the incidence or even mortality rate, those who were active showed a decreased incidence and there was a decreased incidence of cancer, number one. What I've seen basically within our environment in Grenada, in the clinics that I have, obesity is an issue. It plays a very important role in getting adequate control of blood sugar, blood pressure, the cholesterol, etc. And in terms of that, I have not been screening for history of prostate cancer or breast cancer in that environment. But this will be a new screening tool when I have the diabetes clinic asking those questions. But what was very fascinating is that, do you know that in the patients who are diabetic and has prostate cancer, that diabetes per se do not contribute to an increased risk in patients who have prostate cancer. Why? Because in a prostate cancer, the testosterone level is low because of high blood sugar. Many diabetic patients is hypogonadal, or they have low testosterone level. Right? So that's the only inverse relationship that we see in diabetes and cancer, prostate cancer. With breast, yes, diabetes, according to the literature that I went through, plays a very important role. It provides the environment for that. In Grenada, there isn't much data, but I think it exists if we pay more attention to it. I know I went way around answering your question, but I do hope I shared some insight there.
Thank you.
We have another question now from Jean Beckles. Jean, would you like to ask your question?
Thanks. It's Jean Beckles, and my questions to Dr. Matthias. Thank you so much, sir, for an excellent presentation. I wanted to know, how long will childhood obesity potentially affect an individual? And I'm looking at the effects for adult non-communicable disease as well as cancer risk.
Very interesting question, and thanks for that question. Obesity is a disease, and we have to keep that in our mind. It is a disease because it provides or it creates the environment for downstream abnormality. It causes insulin resistance. So that young kid who develops obesity, young girl, she's on the trajectory of developing polycystic ovarian syndrome. She's on the trajectory of developing hypertension. He's on the trajectory of developing diabetes, et cetera, et cetera. So obesity should be addressed early as once it's identified and treat aggressively, because we know the long-term complication of the obesity is of heart disease, of stroke, and as we discussed here today, the presumed relationship with cancer. So we have to address it early. And I do see many of the polycystic ovarian syndrome patients, the females I have in my clinic, they started at an early age with a precocious puberty, getting, let's say, increased weight at a very early age, even at the age of 5, 10, 15. By the time they reach their early 20s, they start having the complications from obesity. So I want us to take home this, that obesity is an issue. And that's why the pharmaceutical companies here in these United States are investing tremendous in products that will cause weight loss. And we are seeing the benefits of these drugs with weight loss. So yes, it may take, because today in our youth, they are less active. Our kids today, I remember as a kid, we had these frequent 15 minutes break throughout the day that we could go outside and do a lot. But today, with the advent of AI and different things, our kids are less active, and we have to find ways to change that, because as we look, over 30% of our kids are already obese in the region. That's a health burden for the Caribbean government.
If you're able to correct the obesity within a year or two, will that long-term risk remain?
Because remember, as you lose that excess fat, the body will, those inflammatory markers will decrease, and thus you will not have the propagation. In other words, the legacy effect will be lost if the obesity continues. So you can reverse correctly, but hopefully that child hopefully that child maintain that lifestyle, increase physical activity, decrease carb intake. But, we could put a caveat here. If there's a family predisposition, if you have a ethnic, let's say a genetic risk there, or there could be certain ethnic background that may contribute to this, it may be an uphill battle. And we have to remember, not all obesity is a problem. There are some folks who have the genetic predisposition, and they're healthy. They do not have insulin resistance. I see that in my clinic often. So yes, you have to screen, you have to examine, look for markers, do the blood work, and that will help you. So to answer your question, if we reverse that obesity, you will have long-term benefits. The sad part of this, in my environment in which I treat obesity, many of these drugs that we use, once it stops, the patient regained the weight, which is a sad thing. They regained it. They lose it. Diabetes, they're off all the diabetic medication, off all high blood pressure medication, cholesterol improve. But once I stop that medication, within the next 3 to 6 months, they are back from the over the 20, 30 pounds percent weight loss they have. That telling you how connected our hypothalamus and the pancreas, our satiety is. That connection between our pleasure center, our satiety center, and our fullness center, how they interplay. Because these fat cells are programmed for survival. They will expand and expand. They have no limit, as I will say. That's their function, to store energy. And by any means necessary. That's why anyone who does any diet, they will lose weight for the first month or two, but they can't maintain it.
Thank you. Thank you for that. Yeah, that was a very good answer.
Thank you.
I've got a couple more questions. One is on a slightly different topic, maybe for Valerie again. How long can cervical cancer go undetected? That's from Vicky Chong.
Okay, so cervical cancer, is very slow in developing, and hence the reason why we ask for persons to be screened and regularly and early, because that can take from anywhere between 10 to 20 years before you can even move from a pre-cancer to invasive cancer.
So it can basically sit there as the
Exactly.
quiet cancer, undetected, but there. Yeah. And then we've got one more. Lindona is asking, Dr. Tellis is asking, she says, Dominica is known for the nature aisle and produces fresh produce and foods for local and regional markets. What trend has been noted in prevalence of diabetes and obesity? So that is probably
so in Dominica,
yes.
Yeah, we do have fresh fruits, vegetables, and ground provisions. But Dominica is also trapped in the global marketing strategies. So our young people will subscribe to the processed foods and the processed items that are available. So while we have all these fresh fruits and vegetables, and we also have all these mountains and waterfalls, and we encourage people to go hiking, we have the National Trail. What is happening is that it's beginning to gain momentum, but again, we have to start from childhood. So when a parent gives a child a chubby to go to school, these drinks, and all these biscuits and all these different things, we are not encouraging to eat local. So there is a massive trend towards going back to the roots, a massive trend towards hiking. And so what is happening now, we have all these different groups going up on a Saturday to hike to the waterfalls, and then we have increased tax on sugary beverages. We're trying to introduce taxes as well on excess salt, and the like. So we are beginning to move towards that, but it is an uphill battle, because the parent who has 5 kids to go to school, they are not going to sit in the kitchen and produce a healthy snack and so on. They'll just get a chubby and so on. So the education is very important, and that is what we are trying to do.
Thank you. That is also true. And similar situation to what we have in Grenada. I mean, we have fruit, we have vegetables, you know, we have fish from the sea, but incidence of childhood obesity is rising. So I think all the islands are facing the same dilemmas, and all the chronic disease commissions are rubbing their heads together, trying to figure out strategies that we can help, you know. Now, I don't know whether we have run somewhat over time. We're now on 7:51. I don't know if there are any more questions. I'm not seeing any more questions in the chat.
No, there's one point I wish to make, and
Yeah,
as we have the audience here, I wish to make that point in regards to hypertension in the Caribbean. I would like, this is just a suggestion, and there is data in the New England Journal of Medicine and also recently in JAMA, the Journal of American Medical Association, looking at treating high blood pressure in Black folks and Afro-American origin. And the trend now is to use multiple agents at a lower dose rather than using one pill and maximize the dose. So what if those of you who are interested, they use a diuretic, a calcium channel blocker, and an ARB, angiotensin receptor blockers, at very low doses. And the results are quite interesting. I just want to throw that out, as we haven't talked about hypertension, and just to make us be aware of that. And I think it's something that I struggle with in my clinic in the Caribbean in regards to blood pressure control. We may have to do a paradigm shift how we approached it in terms of optimizing and preventing the stroke and the heart attack that may occur.
Yes, I agree with you there. I think a lot of it is the education of people in the Caribbean. They take their medication for a short while and then they feel better. So they're like, okay, I feel better. I don't have a headache. I don't need to take it anymore. My blood pressure is fine. And then they'll just take it. They get a headache. They might take it. And it's that lack of understanding about keeping regulated that causes the issues, you know? Well, I think, you know, there's so many topics and so many things we could talk about. And quite obviously, we need to have several more sessions for everyone to join in on several different topics. I think we were already talking about HPV and cervical cancer, and this is really a massive topic and definitely a cancer that could virtually be eradicated if the right approach is taken. So, I mean, I think we need to have discussion on that. We've got hypertension, we've got all sorts of things. So I think we've got several things that will keep us going over the next 3 months. At this point, I think we need to wind up our session. And so just a few little thank yous. First of all, I would like to thank our 3 speakers. I think Dr. Hiller and Ms. Williams and Dr. Matthias. You know, we could have not had this presentation without you. We are endlessly grateful for your input and, you know, beautiful presentations, extremely informative. You've left us with questions, and we will be delighted to have you back again to carry on these conversations. I think we also want to thank Antigua's Ministry of Health, Dominica's, St. Lucia, Grenada, the Ministry of Health for all the Caribbean countries who are here today for promoting this and continuing to promote the fight against both chronic disease and cancers. It's not easy, and we want to thank all the ministries for everything that they're doing. Also, the people who support the CCP, the Grenada Cancer Society, the NCDC of Grenada, Windriff, who are our continued supporters, St. George's University. I'd like to personally thank as well Dr. Lindonna Tellisford, who just works so hard in the background to make sure that all these events take place. So thank you very much for your hard work. And all the chronic disease commissions across the Caribbean, it's not an easy fight. And we really appreciate everything that you are doing for your populations. And this kind of media helps us share our ideas and resources and inspires us to keep going and come up with new ideas. So thank you very much. And just to finish, can I have one word or one line from each of our speakers? So Dr. St-Hilaire, you can go first. One takeaway point you want to give to people tonight.
I would like to say that even if we are facing an uphill battle, because the data is suggesting that things are getting worse, we are also arming the population, we are arming the region, we are taking strides since the 2007 Port of Spain Declaration. We are moving forward. You see the NGOs, and we have to keep the fire burning. We can do it together. I thank you.
Thank you. Well agreed. Yes, Ms. Williams, your takeaway point. You're on mute. Unmute, unmute. You're doing what I keep doing.
Sorry. So non-communicable diseases are the #1 killers in the region. And so we need to individually, as a family, as a community, and as a region as a whole, find a way of pushing this non-communicable diseases agenda so that we can become a healthier nation.
Thank you. Very well said. And Dr. Matthias.
Lifestyle change, increase physical activity, decrease caloric intake. Education is paramount for us to overcome this momentous battle.
Thank you. And I think that's a general point through all the things that all three of you said. You know, it's the chronic diseases, it's the obesity, and it is lifestyle. And it's the change of lifestyle that has come to us over the last 10, 20 years that has crept up on us all. And we need to push back and get back to maybe some of the old ways, more exercise and healthier diets. So thank you very much, everyone. We're going to wind up the session now. I hope everyone has put their names and emails in the chat. You will be hearing from us regarding CMEs. So we will contact you. And just thank you very much. And look out on the CCP for our next event. All right. So with that, I will say good night to everyone and thank you.
Good night.
Thank you, everybody. Thank you.
Thank you guys for being here.
Bye.
Good night.
Thank you.
Bye.
Good night.
Thank you. Good night, everyone.
Good night.
Good night, everyone.
Good night.
Good night.
Good night. Good night, everyone.
Good night.
Good night. Thank you.
Good night from Jamaica.
Good night. I love you all.
Good night.
Dr. Matthias, good to see you. Dr. Good night, everyone. We love you so much.
Love you
Thank
too.
you for the presentation.
You're welcome. Thank you.